All right, three, two, one. All right, my name's Josh, and this is the second episode of the Status Dramaticus podcast. So we have a guest today. I have Rodney. He is a Harford County paramedic. So you want to say hi to everybody there, Rodney?
Hi everybody, how you doing?
So I don't think we can get away from talking about the COVID stuff, and I think unfortunately or fortunately, we're going to end up talking about it either way with whatever podcast for a while until this goes away. But I'm just curious, and I'm sure some of the nurses are curious about what EMS does in the field or what has changed since COVID's come around.
Yeah, so things have been very interesting in the past 2 weeks. There's been a lot of changes for us, and as more information comes in, we start getting a little more concerned. I'd say a couple weeks ago, one of the biggest differences that we saw is in our dispatch, the screening. They would tell us if this was a possible PUI, a possible person under investigation for the COVID virus, and they would determine this off of a few questions that they would ask. And if they answer something as easy as a cough, we have to gown up full body, which is something that we're not used to. I would say in EMS, mostly what we're used to doing is just putting on gloves. But gowning up in our case means putting on at least a surgical mask, glasses, head covering net. I don't know if you.
Oh, the bouffant?
Is that what that's
Yep.
called? A bouffant.
You can work on your French with that.
Yes. Très magnifique. And the gown, of course. And I'm glad to say that on the few instances that I've had to don this gear, once we get there, most of the coughs have been either chronic coughs or, yeah, I coughed earlier today. They are not coughing on a regular basis, and they don't have temperatures or any other type of flu symptoms. So it's a little bit frustrating to have to don all this gear. One of them was a seizure, so you're trying to play a balance act between protecting yourself and coming to attend a patient.
I think it's interesting too. It's like you don't realize the extra time it's going to take to gown up before you touch a patient. Like putting your gloves on was one thing, and then all of a sudden you're asked to put on all these other things. So, and I remember there was a situation a couple years ago where I was in a nursing home, and just as we were getting to the nursing home, they're like, "Oh, she's tested positive for TB." You're like, oh, okay. Well, I go over to the room. There's like a cleaning lady in there. There's like the the patient has the other resident in there.
Yeah.
It's like no one told you anything, and then here we are just showing up, and all of a sudden now you've got to, protect yourself or find the equipment, and depending on the ambulance you're on, every once in a while you're not as equipped as you should be.
Yeah.
But I mean, that's just something interesting too that we're dealing with in the hospital, because how long it takes to gown up. And when I say gown up, if there's someone that's suspicious for it, you've got to put on the N95, you've got to put on the gloves, bouffant, the gowns, everything. And, it takes a little bit more time. And even in critical situations, you got to do that too, because you can't just go running into a room. Even cardiac arrest, you got to think about that stuff.
Yeah.
So, well, that's pretty cool about the dispatch. Were they pretty on top of that when all this came out?
They were, and this past week, I think they've done a little better job of screening the calls, so that maybe those things that were just a single cough didn't sound like they were too sick. Maybe we're not getting dispatched for a PUI so much. The only other difference that we've had in the past week is we have to gown up for cardiac arrest regardless.
Okay. Yeah, I mean, that makes sense. I mean, as far as the current research says, anything that is aerosolizing of it. So it sounds like from what's coming out, when you can look at like the WHO website it sounds like droplet precautions for the most part.
Yeah.
But they also gave like a list of procedures that can generate aerosols, and that's what you're really worried about with the airborne stuff, and which is why everyone's making a big deal about the N95 and the PAPRs and all that stuff. But I did make a list of all the things that were recommended you should wear the N95 at a minimum for, and that's endotracheal intubation, bronchoscopy, open suctioning, nebulizer treatments, manual ventilation, which you end up doing a lot on the ambulance too.
Absolutely.
Turning the patient to prone position. I thought that was an interesting one. That was a recommendation. So I guess you just have the fluid that builds up, and then maybe as they change their breathing pattern, I don't know, maybe that puts more force on the droplets to aerosolize them. I don't know. Someone can correct me later on that one, but
Yeah.
all I know is it's written on there. And then disconnecting the patient from the ventilator, a tracheostomy, so thinking about suction tracheostomies, which, I mean, we don't do that a lot in the ED, but on the floors, they, of course, are doing that. You guys aren't doing that most of the time, but private ambulance might do that every once in a while within our facilities. And then, of course, the big one, CPR. We were just talking about cardiac arrest, and yeah, even if they're intubated, even if you should still be, wearing the proper gear for that stuff when it aerosolizes. Do you guys have any PAPRs or anything on the units?
What's a PAPR?
Okay, so that's all right. That's why we're doing this. So it's a powered air purifying respirator. You might have seen.
I've seen them.
Yeah.
So they got the little motor on the back.
Right.
No, we are not that advanced, and I'm hard pressed to see the immediate need for it. But yeah, talk to me about it.
Yeah. So I mean, it's exactly what you said. It's battery powered. It's got a filter in it. It's supposed to filter out. I guess you would just have to specify on the manufacturing specs on it. But I believe it's 5 microns, which is like right around that cusp of if something's droplet or if it's something is droplet nuclei. Apparently those are also in short supply, so
Yes.
But it's another tool. You have like your N95 and you have the PAPRs. You've probably seen a lot of us in the PAPRs when we go into these rooms, because some people didn't pass the N95 fit test.
Oh, okay.
Yeah,
Okay.
so that's for them. But also sometimes you just don't have an N95, and some people even prefer the PAPRs to the N95 because you're not, having that on your face the entire time.
And I don't want to downplay. I don't want it to sound like I'm downplaying that level of protection. I fully recognize that that the best possible protection that we can have in this times is the best for all of us.
Right.
Because none of us want to get infected by this. So we have not been tested for N95 fitting. I think we're just at a level of put this on, clamp that nose, try to find whatever size is best for you, medium or large. But none of us have been like, you pass and you fail. And it's probably because we have no other type of protections.
Right. Oh, okay. It's just interesting the amount of supplies, and people are, just getting upset about the perceived shortages, or, well, maybe perceived isn't the best word, but apparently people are having trouble getting this equipment, and then they look at disasters like Italy, and they see them all gowned up completely head to toe in the ET outfits, and then you go to New York and you see the disaster striking there. So it's got everyone a little on edge.
Yeah, and it's something that I'm conscious about too. Do I want to use a surgical mask as opposed to an N95? I'm a surgical mask first guy. Our protocols here in this county are not to don N95. I believe it's still the same. It's almost changing every day. But until we do use an aerosol as small as a nasal cannula. But I'm very conscious about it personally because I don't know if we're going to get to a point where these things run out. And am I going to run into a case where I really need it? And what will I do then? Do we have an option to call the hazmat team to either bring us gear, that will fully protect us before going into a home?
Right.
Or just bringing in a whole team that is gowned up and that's wearing the suits. I forget the name of the suits. We'll have to revisit that.
Oh, the Papper?
No. The hazmat
Oh,
tech.
I see what you're saying.
Yeah.
Yeah, they do have a particular name. Maybe that's another one that the listeners can
They
correct us on.
they call them the banana suits in some places.
Right.
When Ebola was going around about 5 to 6 years ago.
The other thing with
A lot of training
EMS
for that.
that I think is really tricky is so you're changing environments when you're all gowned up.
Hmm.
So it's staying cognizant of like what you're touching all the time, which is something that no one's used to. Like you're,
Especially in EMS.
oh, absolutely. So you're going from patient's house into the unit and then off the unit into the hospital.
Yeah.
And it's like with all this infection control type of stuff, it's almost as if you just need all hands on deck.
Yeah.
Like, so people see you coming into the hospital, maybe they open the door for you or, hit the door opener and help you guys in there because, you've been contaminated and you're also in a small space with some of these patients.
And I'm getting a little more of an education on that as I go into the hospitals. Nurses have
I'm
seen
sure
me
everyone's
said,
going to
"Hey,
say
you're
something.
contaminated everything because you're not taking off your gloves when you leave the room." And, that's something that we haven't addressed outside of the hospital. So we're receiving a little bit more of an education once we get in there. So please be patient with us. We appreciate you helping us and being patient with us. So we're going to get this down.
Well, I think everyone's trying, but
Yeah.
it's just like a baseline of anxiety because everyone's
Oh,
just watching the news. Everyone's
understandably
probably
so.
checking statuses on Facebook constantly and then just building it up. And there's even like a COVID anxiety.
Sure.
People saying COVID anxiety is real.
Yeah.
And yeah, like this is a completely unknown thing. A lot of us have never worked through a pandemic before.
Nope.
There's going to be a lot of that's expected of us. And supposedly, Maryland is supposed to hit its peak in 3 to 4 weeks
That's right.
from what the projections say.
Yeah.
So it's just crazy. It's
Yeah.
just crazy to think about.
One other thing I thought to add that is different is that we also have a checklist for people who are symptomatic with flu type symptoms. And if they meet criteria where it's best for them to quarantine at home, we're urging that and getting refusals for that too. So that's very different. Also, the general public that we've seen, although they are calling 911, they're concerned about this too. So when we do end up recommending that they stay home because of the possibility of being exposed to coronavirus and having other options like their PCP, they're agreeing and they're like, yeah, I think I can call my doctor, try to schedule an appointment with him and
Right.
go and see him. So that's interesting. And in addition to that, then the acuity of calls that I've seen has been higher.
Yeah.
Because we are not receiving the low acuity
Right.
calls as much as we have.
Your priority 3s as much.
Yep.
Okay.
Mm-hmm.
And then that's basically been the same thing with the hospital.
Yes.
A little bit lower on the priority 3s and 4s, but very high acuity. Some patients that are just very sick, and that's the interesting part is those patients were going to come anyway.
Yeah.
Like the hospital system was still working hard, and we were still going to get those patients in addition to all these lower priority patients that are kind of unable to see a primary care or unable to get the appropriate care that they need that are for less urgent types of situations. But that's what I think the public might not understand entirely is that we are still, even if it seems like the waiting room is not packed with its normal 40, 50 people, we're still getting very, very sick people.
Yes.
And then with all these precautions in place, like we talked about earlier, like gowning up before you go in every room with a very, very sick patient, you're probably going to be in there a little while. You're probably going to cluster your care, do as much as possible in the room before you step out. So while you're sweating bullets in some of these outfits, you're trying to get as much done as possible before you step out and see the next really sick person.
Yeah. So I'm really impressed with what I've seen in the ERs. You guys are doing a great job. And to know that you're having higher acuity patients that are now even more susceptible to COVID-19. Just very proud of you guys and
Well,
what you're
that's
doing
nice.
to protect them.
Whoa,
So,
where's this coming from?
oh,
These nice compliments here.
you guys are just doing an awesome job.
I'll take it.
I just pulled up my chats
Yeah.
online since we're talking about, you know, not as many patients, and there's only one color on there. So anybody who knows what I'm talking about, chats, it tells you the hospital bed availabilities, and I only see one hospital on red out there. So that's
Yeah.
different.
No, that's good. So, I mean,
That's also very, very different.
this stay-at-home thing is having an effect, and I think from the reports, at least what you see on the news, they are saying that the social distancing and this stay-at-home type of message that we're sending out to everyone is having a positive effect.
Yeah.
So it was all about what they say, just dampening that curve or flattening the curve. I think that's what they were saying.
Yeah.
So, but I also do think it's interesting how pressed we were prior to this, and then you're introducing a pandemic on top of, everyone in healthcare working their butts off already.
Yeah. Well, I hope all the efforts that everyone in our community, from our patient side, we'll just say civilians, to medical workers, are just doing their absolute utmost best to keep that curve down, and we
Right.
can make it through this.
I think we will. I think we'll make it through it. It's just keep repeating those messages. Everyone keep doing what they're supposed to do. Don't come to the hospital. I mean, and it's hard to say that. You can't say don't come to the hospital because there's some things you like. If you got chest pain, you've got all this other stuff coming on, but the normal stuff that you could probably see a primary care for. And if you're ever in doubt, I guess you're still you got to call 911, So that's a tough thing to
we're going to take
talk
care
about.
of you, and we're going to help you get through this and help you make the right choice.
Right.
And if we got to take you, we're going to take you.
Right. Well, let's see. Anything else EMS is doing, or anything changing that you've noticed on your side?
Oh yeah, here's another little interesting thing. We're doing wellness check before we begin our shifts.
That's good.
Yeah, that started at Haverty Base, and now the foundation, who I work for, is having all their employees do it. So you can get your vitals done on a unit, get a temperature,
Right.
and that way there's a record of it.
Yeah.
Are you guys doing that in the hospital?
Well, if we have an exposure, like I had a confirmed COVID patient, and now I'm supposed to, it's like a self-monitoring, and they sent me a form from the hospital. So for 14 days, I'm supposed to take my temperature in the morning and the evening, and there's a form online that I can put these temperatures in, and I can send them. So it's a self-monitoring thing, but I mean, it keeps me, checking up on myself too if I start to develop a fever, because I think majority of cases with the COVID have a fever. I think it was some really high percentage, is like 99% or so had fever when they were with this.
Okay.
And we are getting COVID patients.
Yeah.
I mean, I think Franklin Square had 34 confirmed COVID patients, and I think our hospital was at, what was it? I want to say it was like 8 or 9 or something along those lines.
Okay.
But yeah, I had a definite COVID last week, and then they let you know that you've been you've had a patient, but as long as I was in a PAPR the entire time.
Oh, good.
Because when that person came in, they just looked very sick. So immediately it was like a negative pressure room, and then it was put the PAPR on, cluster your care, and just take care of it, and got them up to the IMC, I believe.
Okay.
Yeah.
And for those who aren't in the medical field who might be listening to this, There seem to be uh, two types of reaction. When I refer to the checklist where you could possibly stay home, it's general uh, flu-like symptoms, fever, um, and aches and pains. But if you can stay home, if you're stable enough, you can wait it out at home. But there are more severe patients, some more severe type symptoms like a respiratory distress,
Right.
where you are probably then urged to come in. But if you could talk a little bit about that, like maybe what could EMS look for in the more severe cases that would be like, yeah, you need to come in.
That's so tricky
Mm-hmm.
coming from an so I know like from our flow sheets and stuff, we had like an algorithm for a while.
Mm-hmm.
And the algorithm involved like shortness of breath, cough, sore throat, fever, and there was one more thing. But trying to pinpoint who has to and who doesn't need to come in the hospital, that gets hard.
Yeah.
But
you're a really sick patient. I mean, what were some of the symptoms they were exhibiting that took them all the way up to the ICU? I assume that
so
like what's it, pneumonia?
so that's the big thing. So a lot of these patients that we see that are in bad shape, they're fatigued.
Yeah.
So we always talk about work of breathing, and they come in with like low O2 sats, like people that didn't require oxygen at home, all of a sudden needing oxygen. And so far from what we hear about this, the virus is that it attacks the lungs. So you're ending up with pneumonia and then ARDS, and then you're working so hard to breathe against this extra fluid in your lungs, or like wall thickening of the cells that are stopping perfusion or diffusion of your O2. And then you just can't breathe, and you're just using all these extra muscles that you normally don't use to breathe, and then you fatigue, you wear yourself out, and then unfortunately you end up with an endotracheal tube. And
the need for the
ventilator.
The ventilator.
Yep, absolutely.
In high demand.
Yep, and that's an interesting thing too. It's just another resource that we haven't depleted, at least at our hospital. But we hear cases of New York. New York is having a rough time. Italy, they were talking about multiple ventilators. So, like the mild flu-like symptoms, I know people want to be tested, but at the same time, it's like, okay, so what's the risk you're really willing to take if you go out somewhere to get tested? Like, so you're waiting somewhere, or you're in a room, and you're probably exposed to more COVID types of situations outside of the facility. So if you didn't have it, you put yourself at greater risk for having it.
And now Maryland has testing sites, but you do have to get
your primary care.
Appointment from your doctor. You got to get a note from your doctor to get tested.
Right. But I know people keep making a big deal about the testing, and actually, there's another thought I had. So it's about the mortality rate. So people keep saying that we're not testing enough, but I believe when you're doing the mortality rate, it's the number of people that have died as the numerator, and then the number of cases is the denominator. And people keep using this reasoning that, oh, we don't know how bad it is because we're not testing everybody, right? But the thing is from what I'm understanding, the mortality rate hasn't changed, even though we're testing more now. Does that make sense? It's like,
if you have it, you have it, and your outcome is going to be your outcome.
So they would. So if you tested more and there weren't as many deaths, you would expect the mortality rate to go down, right?
Absolutely.
But it's not, even with the more testing, as far as I see from the numbers. You see what I mean? So you can say we're testing more, And there were people saying, oh, we don't even know what the actual mortality rate is because we're not testing everybody. But the mortality rates still continue to rise, even with more confirmed cases because of testing. So it's like, okay, well, it seems like it's still getting worse, which kind of is consistent with the peak not quite being here yet. If that makes sense to anybody. I don't know. I just kind of went around that.
Well, we're all in the very early stages of this. So
that's what they tell us.
Yeah.
But I mean, I believe it. I mean, I guess really now's the time to prepare for stuff. So, I mean, they said they were going to open up the convention center downtown to act as a hospital for this situation. And then, the Baltimore hospitals need help. But I think every hospital already needed help before this, and staffing was an issue in a lot of different places. So there's a need all over the place. It's scary. It's scary, but at the same time, it's like we want it to be both ways. So you don't want to scare people to the point where they rush out and they gather all the toilet paper and hoard it in their closets. But you also don't want to, terrify people to make bad decisions. But it's a happy medium between the two. You want everyone to social distance, so you want to scare them enough to do that. But you don't want to scare them enough that they run around and take every supply of something, especially with like our more vulnerable populations, like our elderly and everything. They're having trouble getting stuff, like basic needs, because someone balled up something. It was just, I still don't get the toilet paper thing. That's blown my mind for a couple of weeks now.
We were talking about grocery stores, and apparently a lot of them have been rationing their food. I haven't seen toilet paper in an aisle in like 2 weeks, so I don't know what they're doing with that.
Right. I don't know. I just holding that in the back, and you have to have like a special passcode to get toilet paper. But I mean, that's good too, because I think a lot of the stores are doing a great job, because they're like funneling people along the lines and trying to limit exposure themselves. It's just an interesting world we're living in right now. Like everything's different. Everything's not the same.
Unfortunately, somehow the whole buying up things is a reaction of human nature that we're just not used to seeing. The food disappearing off the shelves. We're just not used to seeing that. But I guess as time goes on, those markets are going to start planning so that everybody is taken care of.
Right.
And we were talking about people being frightened. So people are frightened, but I guess on the other end we're gonna also teach them that you can't just stockpile things.
Yeah, stockpiling things and like using things inappropriately. You like see that a lot too. Like we had like a delivery driver that was just wearing gloves the entire time. Like, so he's touching everything. So he's like in the shop, touching the cardboard boxes that the food comes in, then come to your door, pulling your door handle, having a pen in his pocket, all with the same gloves. It's the same as your hands. You're everything that you would have had on your hands is on those gloves now. You're just wearing hospital gloves.
We're all learning.
Yeah, and it's tough, but I do think the best thing to do, and this is like one of those reasons I wanted to do this podcast, is like you got to keep learning. You got to keep growing in some way, even if you're a healthcare professional, or even if like from being a paramedic and being a nurse, being in EMS, being in the hospital, you just notice that there's not a lot of health literacy. If you know what I mean by that.
Well, I was at that point at one point in my life. I knew nothing about health and healthcare.
Right. And when you don't know stuff about that, how do you make a good decision if you have no concept of these systems in your body and how things work, what medications do? It's a whole nother thing.
So we have to be patient with those who just are not in our sphere and
Yeah,
circle,
absolutely.
and treat them kindly, treat them lovingly, let them know that it is something to be concerned about, and we got to be prepared, but this is how you be prepared, And
Right.
so when you are in the hospital, switching out the gloves, and even when you're at home, washing your hands regularly after you
That's the big one. That's
do
the big one. The more you
certain
hear about
things.
this,
Yeah.
it's like some of the other countries that have been dealing with this as well have had some pretty good outcomes, or at least reported, because I guess you never really know unless you're
Yeah.
there. But
Yeah.
hand washing needs to be easy to do. We
Yeah.
need to maybe find ways to make that easier. Like, when you go into like the restrooms and they have those automatic sensors that never seem to work.
Yeah.
So you're like, oh, screw this. I'm just,
Just gonna flush it. Yeah.
yeah, I'll just.
Use my foot, my shoe, as often as I can.
But I noticed that a lot of hospitals went to those types of
Yeah.
sensors to use. But maybe you do need the old-fashioned handle for the spigot so that you can make sure that you can turn the spigot on to wash your hands.
Yeah.
The simple stuff like coughing into your arm, which is just silly, but I can't even tell you how many times you guys bring in a person on the stretcher.
Yeah.
You know how you're like eye level with them when
Uh-huh.
you're standing, when they're on the stretcher, and they just cough
Yeah.
right in your face.
Yeah. Yeah. We don't want
Yeah, but maybe that's part of health literacy,
that.
unless there's something else going on there. But sometimes it's
Oh,
the case.
I mean, some patients will take the mask on off. They'll just feel really uncomfortable with it.
Well, yeah. No, that's a good point too, because
Yeah.
there's one guy I had not too long ago. He insisted on wearing the mask,
Uh-huh.
but he only wore it over his lips.
Yeah.
So as he's talking,
Yeah.
you can see his top lip moving over it and his nose and just breathing.
Yeah.
And I said, we should probably put this on. He's like, well, I don't like it on like
Mm-hmm.
that.
Yeah.
And I was like, well, you're not, I don't think you're really helping
Yeah.
anything right
Yeah.
now. But we can do better, but I think it's also going to take some education and teaching each other. And like you said, being patient with each other.
Yeah.
Ugh, these things are hard. But I think after all this is said and done,
Yeah.
what do we get out of this?
Yeah.
Do we prepare a little bit better for pandemics later?
Sure.
Do we get better at teaching like health literacy in schools? Like my son,
Mm-hmm.
he's 7 months old.
Mm-hmm.
When he goes to school, am I going to have to, I plan on teaching him everything I can, but
Yeah.
is this something that we need to do in schools? These are thoughts.
Yeah. Again, we're very early into this, but I am already thinking. I lived through 9/11, and
Mm-hmm.
that was world changing. And I could point to the way how airports operate. It's completely different from before 9/11 to after. So I just compare it to that. And how is EMS and how is healthcare going to be after this? Are we going to be wearing masks more often? I think a huge market has been created for these masks that's probably not going to go away.
Yeah.
So are we going to be wearing, a mask and glasses in addition to our gloves on every call? And then in the hospital, are you going to see more PPE being used?
Right.
Because and they're already bringing up that this could be seasonal. It could go away in the summer, hopefully, but it could come right back in the fall.
Well, I think with that, they're using just our history, which, you
Mm-hmm.
should always learn from your history.
Yeah.
And it was that Spanish flu in 1918.
Mm-hmm.
And that's from what you read about that had this heavy hit, and then summer came along, and then as the weather started getting colder, it came back, but no one was prepared for it and killed thousands more people.
Yeah.
So,
Yeah.
and I think the scariest part of this is that we just don't know. We're not there yet. Like, we haven't even solidified if this is airborne or droplet.
Yeah.
So we just go for the most extreme of the isolation precautions, with back to our PAPRs, N95s, all that stuff.
Yeah.
So it's a completely different time, and I think we're going to learn a lot from this. We're going to get through it.
Yep.
But in the meantime, I think we need to start thinking, like, how do we become resilient to these things?
Yeah.
We eat better. We need to exercise more. Like all the things that we should have been doing, but none of us
Yeah.
want to do it.
Yeah.
Now we're on this house isolation and the social distancing. Maybe it's it could be like a self-reflection
Yeah.
type of time now.
I love the responses of people on Facebook and Instagram, playing their music, just doing something to cheer you up, making up lists of music or movies to watch or exercises to do at home.
Right.
But I think once we're able to go back out, we're going to appreciate it a
Oh,
lot
yeah.
more, and we're going to be dying to go out.
Oh, yeah.
Businesses are going to be dying to have it, and we're going to be dying to give it to them.
Right.
So I
Right.
can't wait.
Yeah. No,
Something to look
it's going to
forward
be
to.
good. It's
Yeah.
going to feel good to get out of the
Yeah.
house and have a little bit of freedom again.
Yeah. So thank you to everybody out there who has done whatever they can to make this bearable
Right.
thing to go through as we have to stay at home when
Yeah.
we're not out, doing the bare necessities.
Everyone's going to watch every show possible on Netflix. And then we're all going to just talk about, I think everyone's talking about that tiger. What's the one?
The Tiger Show.
Whatever the Tiger Show was.
Yeah,
Man and mullet with tiger. That's all I know about it.
Yeah.
Well, I think the only other thing I really have for this podcast is one of our listeners asked for more clarification on the last time we talked about MOLST forms. And we briefly touched on like palliative care and MOLST Bs for do not resuscitate.
Mm-hmm.
And the only thing I wanted to bring about that is that a patient can orally revoke, but it only applies to that one transport.
Okay.
Yeah, so just to clarify that, and authorized decision makers for that patient cannot revoke the MOLST.
No.
Yeah, just to be clear.
Yeah.
But because it came up, and I know there's a lot of invasive things that don't seem invasive, like EKGs and stuff that we do with those patients, but it's still considered invasive when we don't do that. But the patient can say, treat me.
Yep.
Especially
Absolutely,
managing pain, all that stuff.
I've had it happen.
That's right.
It's not often, but it happens.
Yep, it happens, and it's just good to know.
It
Just be
is.
clear in your protocols.
It is.
It's hard to memorize that giant book, but we do our best.
They know what they want.
Yeah.
So, and they let you know, I don't want to go. I'm not ready to go.
Right.
So if something happens.
But that's the thing too. In those types of situations, a lot of times it's not around the time of death, It's like you got a UTI,
Yeah.
and I just need antibiotics, so please take me to the hospital.
I'm having some chest pain, and it's treatable.
Right. And when it's treatable, it should be thought about differently.
Yes.
So that's the only thing from the last podcast. And I want to say thank you to all our listeners. With our education nights, I think we had, towards the end of when we stopped doing it, maybe 10 people, but the last time I looked at our views, I had 85 people.
Awesome.
So already that's much better turnout.
Awesome.
All right. Well, I think that's all I have for this podcast.
Great.
Rodney, you got anything to add?
No, that's all. I appreciate you having me here.
Yeah, it's awesome. Thanks for being the first guest. So we just talked about the episode 2 of the Status Dramaticus podcast. If you have comments, questions, ideas for topics, or you want to be a guest, you can email me at statusdramaticus@gmail.com. And also, I post on Facebook, and you can find the channel on YouTube. It's the first search option that comes up, which I was very happy about. The Status Dramaticus podcast. It'll be the first thing you see when you type it into YouTube. All right, so that's all we have for you, and I hope everyone enjoyed listening, and have a good night.